Welcome to this podcast on left to right shunts. I'm Teresa Wu. Special thanks to Dr. Kim Myers for helping with this content. As a reminder, it would be helpful for you to review related materials from past curriculum before you start this series, as it will give you a better understanding of these conditions. In this podcast, we will be discussing left to right shunts. Here are your learning objectives. At the end of this podcast, the students will be able to review basic physiological concepts that are critical to understanding left to right shunts. Describe the clinical presentation of a patient with a left to right shunt. Describe a workup for patients with suspected left to right shunting. And name some general management principles in a patient with left to right shunts and congestive heart failure. As a reminder, congenital heart diseases include cyanotic congenital heart disease. In these lesions, an abnormal connection allows deoxygenated blood from the right side of the heart to flow into the left side and then systemically. This results in cyanosis and often presents at birth or shortly after. This was discussed in previous podcasts. Acyanotic congenital heart diseases include left to right shunts and outflow tract obstructions. In this podcast, we will be discussing left to right shunts. These include ventricular septal defects, atrial septal defects, patent ductus arteriosus, and atrioventricular septal defects. Let's start with a case. Noel is a 6-week-old male. His parents are concerned because he has been struggling with feeding lately. He usually feeds every 3 hours, for about 20 minutes at a time with no difficulty. Starting about 2 weeks ago, his parents noticed that he has been taking longer to feed, though they don't think he's getting much in. In the last week, he has started to look like he struggles to breathe while feeding. Starting 2 days ago, they noticed that he seems to be sweaty when he feeds or cries. You see him in clinic and you notice that he has not gained any weight since you last saw him about 3 weeks ago. On careful physical examination, you notice that he has a systolic murmur and a hyperactive precordium. You notice that he has some subcostal indrawing and you hear crackles in his lungs. So, feeding difficulty and respiratory symptoms are very common in infants. Is there anything about Noel's history that may be a red flag for a congenital heart disease? If he has a congenital heart disease, why did he not present with symptoms earlier? We will come back to Noel throughout this podcast. Let's start off with some background knowledge. In left to right shunts, there is a communication between the chambers or blood vessels of the heart. This communication allows for oxygenated blood from the left side of the heart back into the right side of the heart rather than directly into the systemic vasculature. One example of this is shown here. Depending on the size of the defect, this can result in increased pulmonary circulation. Because oxygenated blood is shunting to the right side of the heart, these patients do not present with cyanosis. Rather, patients with large left to right shunts tend to present with problems associated with overcirculation of blood in the pulmonary vasculature. For example, they may present with dyspnea, respiratory distress, and poor growth due to chronic work of breathing. As opposed to cyanotic heart lesions that present within the first days of life, left to right lesions present later, usually around 4 to 8 weeks of age. Let's recall the physiological changes that occur from in utero to ex utero. Refer back to the podcast on neonatal cardiopulmonary physiology, if needed. In brief summary, pulmonary vascular resistance in the fetus is very high and is approximately equal to the systemic vascular resistance. After birth, the baby takes a breath, the lungs fill with oxygen, there is rapid pulmonary vascular dilation, and the pulmonary vascular resistance drops rapidly. It takes about 1 to 2 months for the pulmonary vascular resistance to fully drop to mature levels. Recall that blood flows from high to low pressure, so the more pulmonary vascular resistance drops, the greater the pressure differential increases, and the more blood shunts left to right. Symptoms, therefore, tend to start around 4 to 6 weeks of age when the pulmonary vascular resistance drops enough to allow more left to right shunting and therefore more pulmonary congestion. So how do patients with left to right shunts present? Well, it depends on the type of lesion and the size of the shunt. In general, patients with small defects can be asymptomatic other than a murmur. For those with large defects, symptoms are due to pulmonary overcirculation and pulmonary edema. These symptoms include fatigue, diaphoresis, respiratory distress, particularly with feeding, and poor growth. When it comes to physical examination, findings again will depend on the type of defect. If there is a significant shunt, there may be vital sign changes in keeping with congestive heart failure. On cardiac exam, you may hear a pathological murmur and feel a hyperdynamic precordium. If the patient has pulmonary overcirculation, you may have physical exam findings consistent with pulmonary edema. This includes tachypnea, increased work of breathing, and diffuse crackles. Patients with severe pulmonary overcirculation will also develop systemic congestion, which includes hepatomegaly and dependent edema, which is most easily seen in the eyelids, back, and labia or scrotum in infants. Let's go back to Noel. He has a history of difficulty feeding, respiratory distress, and diaphoresis. On examination, you heard a pathological sounding murmur and respiratory symptoms. On examination, you notice that he has some sacral edema, swelling in the scrotum, and his liver edge is palpable 4 centimeters below the costal margin. On careful physical examination, you notice that he has a harsh-sounding systolic murmur and a hyperdynamic precordium. You notice that he has some subcostal indrawing and you hear crackles in his lungs. You suspect a congenital heart disease, but given his young age and non-specific symptoms, you also consider the possibility of a respiratory illness, so you decide you need to do some further investigations. So what investigations would those be? If a left to right shunt is suspected, there are some investigations that can be helpful. A chest X-ray could show abnormal cardiac silhouettes and can give you a sense of pulmonary vascularity. An EKG can be helpful as certain patterns can help lead to some diagnoses. You should also consider workup for other conditions on the differential diagnosis depending on the clinical presentation. Ultimately, you will need an echocardiogram, which will be able to tell you definitively if the patient has a congenital heart disease or not. Chest X-ray findings depend on the size of the defect, as well as the type of the defect. For instance, small lesions with little shunting will often present with normal studies. Lesions that cause clinically significant congestive heart failure can show cardiomegaly and increased pulmonary blood flow. Normally, the heart size should span no more than 50% across the thorax on a chest X-ray. You should be able to see pulmonary vessels up to about 2/3 of the way out. In Noel's chest X-ray, you can appreciate that there is a very large heart. You can also see that pulmonary vessels can be seen all the way to the most lateral edges of the lung fields. This is suggestive of cardiomegaly and pulmonary edema. An EKG can be helpful in this circumstance as well, as it can give you a sense of chamber size. Of note, interpretation of neonatal and pediatric EKGs is outside the scope of what you need to know at the pre-clerkship level. For those who are interested, Noel's EKG shows biventricular hypertrophy for age. This is demonstrated by prominent R waves in the right chest leads and increased S waves in the left chest leads. Again, this is a situation where you can request an EKG and look up age-based normal values. You can also call for help with interpretation. So in Noel's case, you see an abnormal chest X-ray and EKG, and your clinical history and exam are concerning for a possible left to right shunt. You call cardiology and an echocardiogram is done, which confirms a large ventricular septal defect. So now what do you do? In terms of general management of left to right shunts, small lesions often just require observation. Many of these will close spontaneously. These patients should be referred to pediatric cardiology for ongoing monitoring, as surgical intervention may eventually be needed. Most moderate to large lesions, or any lesion that causes hemodynamic compromise, will likely require surgical repair. These decisions are made by pediatric cardiology and the cardiac surgeons. Patients with moderate to large left to right shunts are often in congestive heart failure before they are ready for surgical correction, as seen in Noel's case. They require careful medical management of their congestive heart failure during that time. In contrast to heart failure in adults, congestive heart failure in pediatrics is due to pulmonary overcirculation and not due to pump failure. To manage this, fluid is restricted and patients are started on diuretics. Typically, infants are started on furosemide as a first-line medication, and aldactoside is added if a second agent is needed. Feeding and nutrition is often suboptimal when these patients first present. This is supported by fortifying the formula or breast milk and by using nasogastric tube feeding. This is done to ensure adequate intake and also to reduce energy expenditure needed to feed. This is often a highly stressful time for families, and so it is imperative to offer emotional, social, financial, and psychological supports when possible. This is particularly difficult for families who don't live near a tertiary care center, which is where most of these patients need to be managed during this time. So back to Noel. He clearly has signs of congestive heart failure. He is medically managed with fluid restriction and diuretics. To optimize his nutrition, an NG tube is inserted and he is started on fortified feeds. He is carefully monitored until he is ready for surgical closure of his VSD. This concludes the podcast. Here are some take-home points. Left to right shunts cause oxygenated blood to shunt back to the right side of the heart. These can cause pulmonary overcirculation and congestive heart failure. Number 2. Patients with left to right shunts can present with poor growth, respiratory symptoms, and difficulty feeding. These are common symptoms in infants and are usually not due to congenital heart disease. Careful history and physical examination is required to determine which of these patients needs further cardiac workup. Number 3. If a left to right shunt is suspected, chest X-ray and EKG are helpful. Echocardiogram is needed to make a definitive diagnosis. Number 4. Many patients with small lesions do not need surgical management. However, they do require ongoing monitoring. Patients with moderate to large or hemodynamically significant lesions usually will require surgery. And number 5, medical management of congestive heart failure is a critical part of these patients' care. This concludes our podcast. For students who would like to learn more about applied physiology and how it explains signs and symptoms, you can view the supplementary podcast on applied physiology of left to right shunts.